In this video, we will be discussing about Friedrich's ataxia. It is the most common form of inherited ataxia. It is autosomal recessive in inheritance. Chromosome involved is chromosome number 9 and gene involved is frataxin, which is responsible for iron homeostasis in mitochondria. It will cause its disruption and oxidative damage will be occur to the neurons, causing degeneration of neurons in spinal cord and periphery also. What is the pathology? There is extensive atrophy and demyelination in the spinal cord, dorsal root ganglion cells, and peripheral nerves. But characteristically, there is relative sparing of the cerebellum. Cerebellum is involved. Because the peripheral structures are extensively involved, there will be sensory kind of ataxia. There will be no cerebellar ataxia but sensory ataxia, right? That needs to be remembered about Friedrich's ataxia, because as we have discussed, the autosomal dominant in ataxias like spinocerebellar ataxia, DRPA, episodic ataxia, they always lead to cerebellar ataxia. But Friedrich ataxia, first of all, it is autosomal recessive in inheritance. Secondly, it causes sensory ataxia, not cerebellar. Another feature of pathology is there will be sclerosis and degeneration of spinocerebellar fibers, posterior column fibers, and lateral corticospinal tracts. Right, means spinal cord is also involved. Among the cranial nerves, glossopharyngeal, vagus, and hypoglossal nerve are degenerated. So there will be dysarthria, scanning speech, these kind of features in this patient. Then there is also some pathology in heart. There will be myocyte hypertrophy and fibrosis. Together we call them as cardiomyopathy. Right. There will be cardiomegaly. There may be conduction defects. So that is the pathology associated with this condition. There will be focal degeneration of nerves and cardiac ganglia. Means autonomic features of heart will also be there. So this is the pathology of Friedrich's ataxia. Now, two forms of Friedreich ataxia are being delineated based on genetics. See, clinically these two forms are indistinguishable. We can distinguish them only on the basis of genetic sequencing. First is the classic form. In classic form, there will be frataxin gene defect, chromosome 9, that we have already discussed. Second form is associated with vitamin E deficiency. Vitamin E deficiency can occur in these two conditions, A beta lipoproteinemia and associated with vitamin E deficiency, ataxia associated with vitamin E deficiency. These two are distinct genetic syndromes in which there is vitamin E deficiency and some other features and ataxia, right? So classic form we have discussed, A beta lipoproteinemia. A beta lipoproteinemia is also known as Basen-Cohn-Zwig syndrome. There is defect in the MTP gene. Now MTP is involved in formation of VLDL and its transport or secretion outside, means secretion from the cell is dependent on MTP. It is kind of transport protein. Its defect will cause impairment of VLDL formation, and VLDL is the carrier of vitamin E. So there will be deficient delivery of vitamin E to the tissues. So there will be deficiency of vitamin E in the peripheral nervous system also. There will be degeneration of peripheral nerves which will cause ataxia. So this is A beta lipoproteinemia causing ataxia, right? Now vitamin E deficiency can also occur if there is alpha TTP gene defect. Alpha TTP is required for binding of vitamin E to VLDL so that it can be transported outside the cell. But if there will be no binding, impairment of binding, there will be no transport. Again, there will be deficiency of vitamin E in the peripheral nervous system, causing degeneration of peripheral nerves. This is how vitamin E deficiency associated two syndromes are important in ataxia. One is A beta lipoproteinemia, second is ABED. Right, this all is studied under the main heading of Friedrich Ataxia. Right, clinical features of Friedrich Ataxia. The signs and symptoms begin at 20 to 25 years of age and the patient dies by 35 years of age. Means the disease is relentlessly progressive, the disease is very aggressive, the disease is severe, and unfortunately there is no treatment which can prolong the life of the patient. So begins at 25 years, patient dies at the age of 35 years. That is the rule. Ataxia will be there. Sensory type ataxia means there will be Romberg sign positive. There will be cardiomyopathy, conduction defects. 90% patients are involved. There will be type 2 diabetes mellitus. There will be areflexia, but planters will be extensor. That needs to be remembered. Dorsal column lesion means sensory loss and sensory ataxia. What kind of sensory loss? Fine touch, proprioception, joint and position sense, vibration. This kind of sensory loss means the fine sensory loss, the advanced sensory loss will be there. MRI spine is suggestive of spinal cord atrophy, characteristic sparing of cerebellum. Right. Treatment: Idebenone is a free radical scavenger, will reduce the oxidative damage to the neurons, but unfortunately no role in prolonging the life. Riluzole will decrease excitotoxicity. It is also somehow beneficial. If there is ataxia with vitamin E deficiency, we can give vitamin E in such patients. So that is all about Friedreich's ataxia. Right. Most common form of inherited ataxia. Pathology we have understood. Relative sparing of cerebellum. Two forms of Friedreich's ataxia. One is the classic form, frataxin gene involvement, associated with genetic vitamin E deficiency, in which there are two syndromes, A beta lipoproteinemia and ataxia associated with vitamin E deficiency, ABED. Clinical features: begins at 25 years, patient dies by 35 years, ataxia is sensory type, there will be cardiac problems also, there will be endocrine problem like diabetes mellitus also, there will be areflexia with extensor planters, sensory loss because of dorsal column involvement. MRI spine will be showing sparing of cerebellum and spinal cord atrophy. Treatment consists of Idebenone, Riluzole and vitamin E. That's all. Thank you.